بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Good evening everybody. Dear colleagues, on behalf of the Saudi Society for Rheumatology, it's my honor and privilege to welcome you all in this prestigious webinar, which is Best of EULAR virtual meeting. It's a new scientific program yielded and collected from the EULAR e-Congress 2020. As you know, all of you, that EULAR introduction was in 2000, and the annual European Congress of Rheumatology has become a good platform for exchange of scientific and clinical information. This year, unfortunately, because of the COVID-19 era, we have it as a virtual meeting. And maybe most of you faced some technical issue despite a lot of effort was done by the EULAR, but again, still there are some technical issues while attending some of the sessions. So several important sessions was missed from some of us. For this reason, the Saudi Society for Rheumatology are delighted to offer Best of EULAR virtual Congress experience, where the main objectives is to share the new researches and abstract which was mentioned during the EULAR, and to highlight the update management of some of the rheumatic diseases. We tried to cover most of the rheumatic diseases in the coming 2 days. So these 2 days, tonight we will have 3 sessions. The first one will be about rheumatoid arthritis. The second one about spondyloarthropathy, which will include ankylosing as well as psoriatic arthritis. And then it will be followed by the third session, which will be about crystal-induced arthropathy, osteoarthritis, COVID-19, and rheumatic disease. During the third session, we will have a parallel session with our colleague, the pediatric rheumatologist, for which they will have highlight about all new update from EULAR 2020. To have these, just to make it clear, how to, for our colleague, the pediatric rheumatology, to get the room 2, it will be shown when you register. So I want to move the slide. It will be shown when you registered, as you can see it here. Here is the program that I have mentioned it, and all of you have it. Here you can find like an icon. When you register, you will find room, change room. For the pediatric rheumatology at 21:45 minutes, they can click room 2. So room 2 will be for the pediatric rheumatology and room 1 will be for the adult rheumatology. Another important issue that I have to mention it when to start with regarding attending the meeting, it's better for the audience to use the Chrome. It will be more clear and persistent. So this is just one idea, and please close all the VPN and connect directly to the internet to avoid interruption. During preparation for the Best of EULAR, actually, as you know, it's just 2 weeks after the EULAR. We tried our best to collect everything. So we are proud to have actually an eminent national speakers, as well as our guest international speaker, Professor Joel Kieber. They have worked actually extremely hard in the past 2 weeks to collect all important data from the EULAR 2020. Our speaker actually uniquely placed to highlight the key theme, which is Best of EULAR, and the update, the current practice in the field of rheumatology. We are also grateful and thankful to our speakers, chairperson, the organizers, for their excellent engagement in creating Best of EULAR in quite limited time. My deepest thanks to Dr. Fahed Al-Anizi for his great efforts while preparing for this webinar, and special thanks to Synergy Health UK scientific medical company for helping us in collecting slides and abstract from the EULAR. Finally, the Saudi Society for Rheumatology would like to thank Pfizer Saudi Arabia branch for their partnership and valuable support for this activity, which is the best of EULAR 2020. Also, I would like to thank Pfizer representative, Dr. Khalid Abdul Shakur, for his great effort during preparation of this webinars. At the end, I would like to just give few housekeeping issue. Another thing, that after each session, there will be a question and answer, which will be moderated by the chairperson. So kindly write the question at the site of questions, so it will be ready during the question and answer session, as well as we encourage all attendees to attend all of these webinars. Really, I wish, inshallah, you will have a lot of advantage from attending this session. And at the end of each session, there will be an evaluation form for the speaker and the session. And at the end of the day, also, we have evaluation form, just 3 questions about the day. It's essential to write it in order to have the CME hours, as well as to improve our activity in the future. Now, I will give the chair for Dr. Hussein Halabi. Dr. Hussein Halabi, all of you knew him. He's a famous consultant, senior rheumatologist from King Faisal Specialist Hospital in Jeddah. He's the former president of Saudi Society for Rheumatology from 2013 to 2016. He is also the former president of Pan-Arab Association of Rheumatic Diseases, EULAR, from 2010 to 2012. Also, he's the founder of Rheumatology Academy for Continuous Education and Training Initiative. He's very active in all fields as a presenter, as a speaker, national and as well as international, very active in the research and publication, and he shared several committees. So the chair for you, Dr. Hussein, and you can start the session.
Good evening, everyone. Assalamu alaikum wa rahmatullah, and thank you, Dr. Reyes, for the presentation. I would like to thank the Saudi Society for Rheumatology, the invitation to share this session with 2 great speakers. I would like actually to inform you that this session will be quite unique, and I'm sure all other sessions will be unique. This is actually the effort of all the faculty here. We're gonna present to you in this session the most important abstracts concerning rheumatoid arthritis, targeting different areas, including clinical, basic science, and other interesting topics. Without any further ado, I would like to present our first speaker, Dr. Mohammed Al-Amer. Dr. Amer, he's a dear friend of mine. He's associate professor at King Saud University. He's the founder and the president of the Charitable Association of Rheumatic Disease in Saudi Arabia since May 2016. He is chairman of event management and conference committee at College of Medicine, King Saud University. Dr. Amer actually has several publications in reputable medical journals, and I had the pleasure actually sharing with him several publications. Dr. Amer, he will speak to us about what's new in rheumatoid arthritis. Dr. Amer, usually I would say the podium is yours, but the mic is yours this time.
Bismillah ar-Rahman ar-Rahim wa sallallahu ala Rasulullah. Thank you, Dr. Hussein, for the kind introduction. It's a privilege for me to be presenting the update on RA. And I would like to thank the Saudi Society for Rheumatology for inviting me to give this talk, and the great work and effort that have been given by all of the members during this COVID-19 pandemic. Now, this is my disclosure. I'm gonna take you into a small trip into the most of the oral presentations in rheumatoid arthritis abstract, and these are the area that I will hopefully cover during my presentation. Now, let's start with the investigator-initiated controlled trials. To me, investigator-initiated studies are usually of the prime importance because they are usually targeting a specific research question that can be translated into a change in patient care. The first study is the North Star study. The North Star study is looking at the initial therapy of patients with rheumatoid arthritis. And this study is an investigator-initiated study, multi-center randomized, which included many countries from the Scandinavian region with Netherlands and Iceland. The patients who were included were early RA patients, and most of these patients were seropositive and had acute phase reactants, which we call usually the cohort enrichment recruitment. And the result of this study, they have shown that using conventional DMARDs compared to other biologics, you can achieve an almost similar C-die remission at 24 weeks, which is really important. So optimization of DMARD can really lead to a better response, especially in early RA. Now, in this study, they have used a non-inferiority analysis, and as you can see here, the only one that had achieved this outcome favoring the biologic is the abatacept, but it was really marginal. What we could listen from this study is that appropriate use of conventional DMARD and optimization of conventional DMARD would lead to reaching a C-die remission at 24 weeks, which is similar than what we see with biologics from different mechanisms of action. The second study, which is again a very important study, is the Architect Rewind study. And this study, it's based on the strategy of tapering and withdrawal of biologics. Now, this study is a multinational study, and you could see the inclusion criteria was not only remission at 1 year, but a solid remission, 0 swollen joint, 0 tender joint, and a very low DAS28 or DAS44 activity. Patients were then randomized to, after having remission for a 12 months duration, to a stable dose of TNF inhibitor versus a tapering to half, then discontinuation. In this study, they have found that the rate of flare is 5% in the stable dosing versus 63% in the tapering and discontinuation. You could see that after about 4 months, the rate of flare increases, and this is a very important clinical point, that when you taper your therapies, you have to observe these patients in the first 4 to 6 months for evidence of flare. Now, this study has been a little bit disappointing for me because we always aim at reducing therapy whenever a patient is in remission. Hope is not lost. It's just that we need to follow these patients, and in this study, reinstitution of the TNF inhibitor have led to reinstitution of the remission in these patients. So I think that trying to taper therapy is an acceptable strategy for both patient and physician, and will benefit the healthcare in general. The next study is the NORDRUM study, where the investigators have included patients receiving infliximab, not only with rheumatoid arthritis. And the idea of this study is to see if drug level monitoring would affect rate of remission or adverse events. So they have followed a specific protocol based on the level of infliximab in the blood after specific infusions. And in this study, they have not seen any difference in the rate of remission or response with drug monitoring, so it did not add value. The only thing that added value is that the rate of infusion reaction was less in patients with in the target drug monitoring arm. So the conclusion is that monitoring of infliximab did not really change the outcome of patients except in the rate of drug-related infusion reaction. Now, I will go to the pharmaceutical sponsor control studies, and we have very promising studies. With the first drug is olukizumab. Olukizumab is an IL-6 blocker. Now, olukizumab is different than tocilizumab and sarilumab, where the two later drugs that are already approved are blocking interleukin-6 receptor, whether olukizumab is a blocker of the IL-6 ligand itself, and there are many different IL-6 ligand blockers like circumab and clazakizumab, but the importance that olukizumab blocks the GP130 region, which is actually the most important region in the activation of the IL-6 receptor and activation of the JAK-STAT pathway inside the cell. So basically, it's a standard protocol. We could see here that the patients who are recruited in the study have a very high disease activity, with almost 85% of these patients are above DAS28 CRP of 5.1, and the remaining are moderate disease activity. And these patients received two different regimes, and the primary outcome was at 12 weeks. As you could see here, we could see a little bit a higher rate of ACR20 response than what we really see with other clinical trials, reaching 70%, which is actually a promising for patients who did not achieve a good response with conventional DMARDs. The rate of adverse events of olukizumab are almost similar to what we see with IL-6 blockers, especially in disturbing liver enzymes. The next drug is SM03, which is a recommended anti-CD22. It is a phase 2 randomized trial looking at two different doses of this anti-CD22, and the primary response was at 24 weeks, and you could see a similar ACR 20, 50, 70 of 60, 40, and 20%, the usual that we see. And the rate of adverse events is almost similar to what we see in rituximab in these patients. Now, this is quite interesting. MBS 2320 is a novel selective modulator of the immune metabolism. So this drug is one of the few drugs that have two mechanisms of action. So it blocks TNF, and it has also an effect on the bone and cartilage metabolism. So it's protective for the joint. And in this study, this is a phase 2 study, of course. The MBS company is now signing with Janssen to develop this drug, and these patients who have received the drug have shown promising results in view of response. Now, they did not do some graphs, but you could see here that the response of the ACR50 at 12 weeks is 11% compared to 2.5. You cannot really judge on the efficacy with the small sample size, but hopefully if this go to a phase 3 program, we're going to see a better response. I just like to remind you that many drugs that had a dual target have failed, especially in the spondyloarthritis clinical trials. So I think maybe this dual mechanism of action might work actually in RA. Now, next is one of my favorite topics, is about interstitial lung disease and rheumatoid arthritis. We have very important studies looking at that. The first study from the US looking at a large database in the US, the Analytic Joint Man database, and they have actually looked at the prevalence of interstitial lung disease, and this is one of the main conclusion that 3.8% of patients with RA had ILD after or at the diagnosis of RA, and the mean year of time to ILD after the onset of RA is 2 to 3 years. This is very important because we now see patients developing ILD an earlier time than what has been described in the past. Now, the clinical characteristics of patients who develop ILD, these are actually seropositive, sick patients with extra-articular manifestations, erosive disease, and when they did the logistic regression, they have seen no relation to methotrexate with the development of ILD. This takes me to the next study, which looks at methotrexate and rheumatoid arthritis-associated ILD. And as you know, methotrexate is associated with lung drug-induced pneumonitis in RA patients. Some people have blamed methotrexate to be the cause of the appearance of ILD. There have been a study published a year ago from 2 large UK databases showing actually that methotrexate exposure protects from ILD development. In this retrospective case control study, they had an excellent number of patients, 482 in the RA-ILD with 700 as controls, and they have shown that methotrexate is not associated with development of any ILD form, and actually they have shown that methotrexate exposure reduces the risk of developing ILD. You can see this is a study from different countries, and they have replicated the data on different databases. So I think the two study that we have seen now, the study that's published from UK and this multinational study, have clearly shown that methotrexate is actually associated with a decreased risk of developing ILD rather than causing the ILD itself. The next study looking at RA-related ILD is what has been done in the scleroderma literature. There are circulating markers in interstitial disease, either IPF or connective tissue disease-related ILD, namely KL6, SPD, and CL18. And these are actually biomarkers of lung injury or inflammation. KL6 is a mucoprotein secreted by proliferating or damaging type 2 alveolar cells. SPD is a lipoprotein secreted by pneumocyte and has a role in lung defense. And the CL12 is a chemotactic factor produced by alveoli macrophages, which has a pro-fibrotic effect. And what the study have shown that KL6 is elevated in patients with RA-related ILD, so it can be a predictor of ILD presence. And additionally, it also correlates with the progression of ILD. So here, with the follow-up patients, they have seen that patients who have an increase in the KL6, they have progression in their ILD based on the HRCT scoring. There is another poster related to this study, which also showed that KL6 level also predict relapses and acute exacerbation of ILD which could be an important monitor in the future once it's available in the market. The next study is looking at abatacept in interstitial lung disease, and this is from a Spanish cohort where they have used abatacept in these patients. You can see here in the baseline demographics that many of these patients were on DMARDs and were on anti-TNFs, but they are not anymore on these anti-TNFs. And you could see here that using abatacept in these patients, of course, it also helps in controlling joint disease, but it also has stabilized patients. So you could see the modified medical research council dyspnea scale. So this is a dyspnea scale from 0 to 4. This is the FVC, DLCO, and HRCT. And the light gray bar is showing the stabilization of ILD. So about 70% of patients have stabilization. You have about 20 to 15% improvement, and a minority of patients reaching 10 to 15% deterioration. So what we could understand that abatacept use in RA-ILD does not only help in joint, but also can have a positive effect on stabilization of ILD. You know that stabilization of ILD is actually one of the target goals. This is another study looking again at patients using different biologics with RA-ILD, and they have clearly shown here that using non-TNF biologics have a positive outcome on progression of ILD. So do not use anti-TNFs. This is the bottom line. The next part of my presentation is about large databases in rheumatoid arthritis. The first study is the coming from the VGBase, which is a WHO related database, and they have looked at adverse events with thromboembolic disease. And as you know, the JAK inhibitors have some increase in the risk of developing DVT in PE, and this large database have proven that in Europe and the US, for both products. This cohort study have also looked at DVT and PE, but looked at it in a different way, where they have seen a clear association with disease activity and the development of venous thromboembolic disease. So the higher the disease activity, the higher the risk of developing thromboembolic disease. So whenever you reduce disease activity, you lower the risk of thromboembolic disease to what is seen in the normal population. The next study is again looking at herpes zoster in patients receiving different biologics. And as you know, if we take the patient on conventional DMARDs as the control, all biologics are associated with increased thromboembolic disease, but namely the monoclonal TNF inhibitors, infliximab and adalimumab, and of course the JAK inhibitor, which you can see a significant incidence rate in these patients. Of course, other risk factors from different registries, including the corona registry, you could see that the glucocorticoid dosing plays an important role in the development of herpes zoster, especially in elderly patients. My next study is the JACPOT study. The JACPOT study is to evaluate the effectiveness of JAK inhibitors to compare to other biological DMARDs. And this is from different registries, about 14 registries, mainly from Europe. And the total number of patients are 25 patients with moderate disease activity. And you can see here that the drug survival of biologics is almost similar, and the JAK inhibitors have a similar drug survival, despite that they are oral and they have a small half-life, which is actually a very reassuring study that JAK inhibitors might have a similar drug survival compared to other mechanisms of action. They were a little bit higher than TNF, but not clinically significant. This study is from Canada, from the Ontario region, where they have looked at drug survival in patients with TNF inhibitors and patients on tufasnib, and they have seen that tufasnib retention is similar to patients with TNF inhibitors when they are on methotrexate, but might be a little bit higher in patients who are on tufasnib monotherapy compared to TNF inhibitor monotherapy. The ANSWER study is a continuation of many studies published by the Japanese group by Dr. Ibina, and this study is also looking at drug retention, and this is a very detailed study, so I'll take you quickly on it. So they have analyzed based on the reason of drug discontinuation. So here it's about lack of effectiveness. So if you take abatacept as your reference drug, you see more discontinuation with adalimumab, certolizumab, etanercept, and infliximab in patients who are biological DMARD naive, but in switch patients, it's only better than adalimumab, and certolizumab is superior to abatacept. Tufasnib is similar to the other drugs, and the other TNFs are also similar. If you look at adverse events, as you know, abatacept has one of the safest profiles, so it's actually better than most of these medications in biological naive, and switched only etanercept has been shown to be superior to abatacept compared to the other biologics. If you look at discontinuation due to remission, you could see that anti-TNFs do actually very well in addition to tocilizumab compared to abatacept. And this is again a chart showing the differentiation of discontinuation in naive patients and in switch patients. This is a very detailed study which have given a lot of information even from the previous study. I just advise you to look at the previous publication of Dr. Ibina. Moving to fatigue in RA, there are two very interesting studies with conflicting results. This is a study from the Rabbit Registry from Germany, where they have looked at fatigue in patients receiving different biologics, and they have shown that tocilizumab is the only drug that have significant response. You know, fatigue is very complex and very difficult to measure and very subjective. We need to look at more data, but they have looked at what are the predictors of achieving a response of low fatigue. For example, female sex, former smoker are all against developing this kind of response. But IL-6 have shown that it has the best effect on fatigue. JAK inhibitors have missed it, but the anti-TNFs and abatacept are really crossing the one line. The second study is from a Dutch biologic monitor registry, where they have actually looked at fatigue as an adverse event related to biologics. To me, this was actually very difficult to interpret and very difficult to look at the data, but they have looked at what are the possibilities that a patient would develop fatigue due to starting a biologic, because usually biologics improve fatigue by improving disease activity and other mechanistic processes, especially in the brain. So this could be another paradoxical effect similar that we've seen with many biologics like the anti-TNFs causing paradoxical psoriasis. I would really just observe future publications related to fatigue relate an adverse event in a patient receiving biologics. Then I'll take you to the future, artificial intelligence rheumatoid arthritis, and this is really a big evolution in RA management. The two important studies on artificial intelligence that I have seen in the EULAR Congress is that artificial intelligence using specific models can accurately read the ultrasound images similar to an experienced rheumatologist or radiologist. So there was no significant difference between the standard of care or the gold standard, which is the rheumatologist, and the model put in the ultrasound. So basically, you put a probe even if you're not experienced, and then you're going to have a clear or accurate ultrasound scoring for power Doppler and grayscale. The next study, which has been always a problem in clinical trials, is reading the radiographic progression from the Sharp-Van der Heide score. And you could see that many clinical trials using biologics, there is a very small difference between the placebo arm and the biologic arm. And there have been questioned, are there any possibility that biologics cause remodeling, or this would be a wrong reading by the radiologist? This study is showing that when you integrate thousands of images into the computer, it can accurately read the joint score and give you a more accurate score compared to what radiologists do in the centralized areas. This is the last study on artificial intelligence, where a Korean center have looked at predicting response based on some variables. So they have looked at biologics and they wanted to see what are the variables that would predict response. To me, when you look at these variables, they are all non-specific, and I cannot really take these findings into my practice, because if you say that a predictor for adalimumab response is a prednisolone dose, it doesn't really mean thing for you as a clinician. So maybe having, and one more point is that prescribing a drug is confounded by many points, by the physician, by the patient, by the coverage. So using these variables might not be adequate to predict response to a certain biologic. So a patient who responding here to adalimumab might also be responding to tocilizumab, golimumab, despite that this have a negative mark on their model. I will end up with some abstracts. One of them is a very interesting abstract coming from China, where they have looked at the microbiome of pre-RA patients, high-risk RA patients, well-established RA patients, and controls. And they have seen that the microbiome of these three groups is different. And then what they have done, they took the they did fecal implantation for CIA mice, which are a mouse model for RA. And they have seen that if you transplant or implant the fecal matter of patients who are high risk of RA into the intestine of these mice, they have a higher chance of developing RA. So the microbiome is not only important in spondyloarthritis, it's also important in RA, and this is also seen by the activation of the Th17 pathway, which is it has a role in RA, despite that IL-17 blockers did not work in RA, but it has an important role in RA pathogenesis. The last study I would like to conclude with is the TARA study. As you know, the TARA study is a randomized controlled trial from different centers in Netherlands, which have looked at tapering of conventional DMARD compared of tapering of TNFs. They have multiple publications of the Annals of Rheumatic Disease, and they just published this month in Seminar of Arthritis Rheumatism their data on patient-reported outcome. And there is clear differentiation between the impact of tapering and flare of patients with the tapering. In this study, they have done a cost-effective analysis looking at tapering of conventional DMARD and keeping the biologic, or tapering of the biologic first and keeping the conventional DMARD. Now, if you see here, the total direct cost is obviously increased in patients who you taper the DMARD, the cheaper drug, but it's really balanced with an increased total indirect cost when you taper the TNF, which might cause a non-significant 10% increase rate of relapse in patients who are having tapering of the biologic prior to the DMARD. So at the end, you can see the quali yearly quali is almost similar in these two. Now, this is a model where the probability of being cost effectiveness is obviously going toward tapering the biologic biologic rather than tapering the conventional DMARD. With this, I would like to conclude, Mr. Chairman, is that there have been excellent studies in this conference showing new promising target pathways in the treatment of RA, different than what we have now. There is a better understanding of RA-ILD in view of epidemiology, risk factor, biomarkers, and therapies. Monitoring and tapering of all therapies still carry many challenges, especially in the drug-free remission achievement. And I can see that artificial intelligence might take an important role in improving imaging interpretation and apply personalized medicine in our patients. I would like to thank again the Saudi Society for Rheumatology for inviting me, for Pfizer for sponsoring this activity, and Synergy Medical Office for helping preparing the content of this talk. Thank you.
Thank you very much, Dr. Amer, for this beautiful and comprehensive update about rheumatoid arthritis. We're going to take 2 or 3 questions before we move to the next presentation. So the first question is, in the study that looked at the tapering of anti-TNF, what percentage of patients who flared up actually had failed more than one biologic?
These were all biologic naive patients, so they were started on their biologics. So they were well distributed upon the different biologics. Maybe there was a higher number on etanercept, but this was their first biologic, and they had to achieve remission for a whole year prior to the study inclusion and tapering.
Very good. I have a question about those patients who developed RA-related interstitial lung disease. Regardless of the availability of specific treatment, which option do you think is appropriate to be used? Non-TNF biologics, methotrexate, or what else?
So what we usually do if a patient develops RA-related ILD, now many centers might continue the methotrexate despite the presence of ILD, but what in our center, we have an ILD center, and usually we see this patient with our colleague pulmonologist. We tend to discontinue methotrexate and diflunomide because it carries a risk for RA-related pneumonia or lung-related pneumonitis, which might be lethal for patients who have an underlying ILD. Now, in view of the non-TNF biologics, the standard of care that we use is rituximab in most of these patients, combined with MMF and, of course, steroids. If a patient has any contraindication to rituximab, as you know, tocilizumab is safe in ILD based on the data of the systemic sclerosis FASCINATE study. Now, this registry have shown us that abatacept is also a possible option that we could use in RA-related ILD. And you know that T lymphocytes are important in RA-related ILD, so it might be an important target. it's really important that when you have an RA-related ILD, your first goal is to stabilize rather than improve, unless the patient has a very early ground glass appearance with no evidence of lung fibrosis on the imaging.
Very good. I have a question concerning the RA, interstitial lung disease markers. Do you think they can be used in the future as a marker, a prediction marker to determine which treatment option you should avoid?
Now, in the study by Dr. Jerem Avwek, of course, Jerem Avwek works a lot on scleroderma, and they have published the same data on systemic sclerosis. The issue is that these biomarkers now predict whether you have ILD or you don't have ILD without looking at the CT. And this is exactly the same data you're going to see with idiopathic pulmonary fibrosis with our pulmonary colleagues and in scleroderma-related ILD. Now, do these biomarkers predict the development of ILD in the future? I think we need to do a prospective study where we take it as baseline and then follow a very large patient population. Or if you have, of course, the frozen serum from these patients 5 or 10 years ago, and then you know who developed ILD, you can really see if these are predictive or not.
Okay, I think we had enough questions, and just in order to be on time, on behalf of all of you, I would like to thank Dr. Mohammed Umair for this great presentation. Thank you, Dr. Umair. Thank you very much. Next is a well-known person. He's Professor Kramer from the state. Professor Kramer is Director of Research Division at the Center of Rheumatology. He's actually, in 2001, he founded Corona. Well, not this Corona. I mean, it's a registry. It's a registry of patients with rheumatic diseases that has contributed 144 peer-reviewed manuscripts to the rheumatology literature. He's the master of ACR and has served on the editorial board of Arthritis and Rheumatism, the Journal of Rheumatology, and Arthritis Care and Research. Professor Kramer will talk to us about JAK inhibitors for the treatment of patients with RA, learning from real-world experience. Professor Kramer, the mic is yours. Thank you.
Thank you so much, Dr. Hussain. Dr. Mohammed, great presentation. Really enjoyed it. And good evening to my colleagues in Saudi Arabia. So it's my pleasure, and I want to also thank the organizers putting these slides together. It's been a pleasure working with them, and hopefully we can share some bits of knowledge, and I always like to learn from my audience, so I look forward to your questions. This is a disclaimer, which I will not read. You can read at your leisure. Here are my disclosures. Here's the agenda, what I will cover. First, the value of real-world data, the effectiveness and persistence of JAK inhibitors in patients with RA treated in the real world. And lastly, the safety of JAK inhibitors in patients with RA in the real world. Now, we're going to start with a question. My understanding is there is a delay in your ability to access this question, so I will read it. For how many adult patients with moderate to severe rheumatoid arthritis have you prescribed a Janus kinase that is a JAK inhibitor within the last 12 months? And your choices are more than 20 patients, 6 to 20 patients, 1 to 5 patients, or no patients. And I'll give you some time to register your response. And I am looking forward to your answers. So, interesting distribution. About a quarter of you have never used a JAK. Another 35% have used it in 1 to 5 patients. Another, let's say 28, 29%, 6 to 20 patients, and a minority really, 12.5%, have used it in more than 20 patients. So that's interesting. My sense is that we're learning about JAKs, and that's great. That's good. Let's move on. Value of real-world data. Real-world data is defined by the EMA as routinely collected data relating to a patient's health status or the delivery of health care from a variety of sources other than traditional clinical trials. Real-world evidence is information derived from the analysis of RWD. I have been into real-world data for a couple decades. Keep in mind that we're treating a lifelong chronic disease and that randomized controlled trials last typically about 6 months. So there's a small window representing the evolution of disease. In addition, there are various inclusion and exclusion criteria in randomized controlled trials, which would not necessarily be relevant from real-world data. So RWD can give us information on long-term safety, comparative effectiveness, all kinds of specific safety challenges, and a window on what happens to the patient beyond 6 months, and what happens to the typical patient who doesn't have 15, 10, or 20 swollen joints at baseline. I know in my practice, the typical number of tender and swollen joints is about 7 or 8 and 5. So real-world data tells us very different things. Next slide. Okay. So what are potential strengths of real-world data? I think I have reviewed that. More diverse, heterogeneous, of course. Effectiveness was what we get from real-world data as opposed to efficacy. Detailed longitudinal information and comparisons. So how does real-world data influence the treatment landscape in RA? There are head-to-head trials of methotrexate, which have shown that it is not more efficacious than other conventional DMARDs. And that's clearly not what we've learned. I did a bunch of studies on RA way back in the 80s. And we found it to be very effective, particularly in people who had failed other conventional DMARDs. So you get a somewhat different picture in the real world. Safety signals from TNF and RA emerge both in the RCTs, but I would say perhaps more from real world data. And disease activity, what is the evolution of disease activity from patients who are on these drugs for a year or two or more? And I think that's really what we're interested in. I cannot tell my patients that the evidence over 6 months is that they will do well. They'll say, well, doc, I'm 44 years old. What about when I'm 50? And that's what we get from real world data. So effectiveness and persistence of JAK inhibitors, and we will consider all the JAKs, but we have to keep in mind that because tofacitinib was approved in 2012, that the overwhelming amount of data on safety and effectiveness from JAKs is in fact derived from our experience with tofacitinib. Randomized controlled trials suggest that JAK inhibitors are at least as effective as TNF inhibitors in patients with RA. From the Corona database, our most recent look is after failing methotrexate, 37% of practitioners in the US will go next to a JAK inhibitor rather than a biologic DMARD. And it did not start out that way. In 2012, 2013, they were rarely used. But like everything, the more experience we get with these agents, the more likely we are to use them. And as I said, most of the data is related to tofacitinib. So there are various real-world registries. One of them is my friends in Australia called OPAL. And they have done a great job with putting a registry together. So they compared conventional DMARDs with biologic DMARDs plus conventional DMARDs. So TOFA plus CS DMARDs, BDMARDs plus CS DMARDs. And if you look at the patients in this registry, most had moderate or high disease activity by CDAI. 25% in each with moderate disease activity, 51 and 53% with high disease activity. Most had been on a prior conventional DMARD. And what we see here is that TOFA, compared with biologic DMARDs, was more frequently given as monotherapy. And that may reflect the fact that TOFA was typically used after biologic DMARDs. And most of these people had, in fact, been exposed to prior conventional DMARDs, and perhaps they were stopped as they were felt to be non-efficacious. If the head-to-head comparison of tofacitinib with biologic DMARDs for DAS28 ESR and CDAI is depicted on this slide. The red is TOFA, the green is other biologic DMARDs. None of these differences were statistically significant. So what we get from this observational study in Australia was that, in fact, there is no meaningful difference in these outcomes between tofacitinib as representative of the larger class of JAK inhibitors and a biologic DMARD. This is the SCQM registry that my friend Axel Fink runs. It's a Swiss registry, and here's the baseline information. Tofacitinib plus conventional DMARDs, plus a TNF inhibitor with conventional DMARDs, plus an OMA, stands for other mechanism of action, other biologic DMARDs. These are baseline criteria, and you see that greater than or equal to 1, including methotrexate and concomitant medications, was actually more common with TNF inhibitors. Greater than 1 patients who had been on other conventional DMARDs was fairly evenly distributed. So let's look at these outcomes. This is a KM curve of survival, probability to stay on treatment. And at the top here, the red line is tofacitinib. At the bottom 2 lines are TNF combination treatment and TNF monotherapy. So over a period of 3 years, the likelihood of remaining on tofacitinib was numerically greater than those alternatives. And this is drug discontinuation in patients with RA on these 3 interventions. And again, we see the likelihood of having the drug discontinued was less with tofacitinib than other mechanisms or TNF inhibitors. The likelihood of an intolerance or an adverse event was slightly greater with other mechanisms versus TNF inhibitors. So, summary of the efficacy data. RCT data have suggested that JAK inhibitors are as effective as TNF inhibitors for the management of RA. This is certainly my own personal experience in 60 or 70 patients. I really love this category of medications, and it's the experience from the literature so far. The OPAL study, lower treatment discontinuation with TOFA compared with TNF inhibitors, similar persistence with monotherapy or combination therapy compared with TNF inhibitors. So we're going to move on to one of my favorite topics, safety of JAK inhibitors in patients with RA in the real world. We all live in the real world. RCTs are even conducted in the real world. But real world data means observational data from physicians and patients in clinics throughout different countries. Safety of JAK inhibitors in the real world. As real world evidence for JAK inhibitors in RA substantiates safety data from the RCT programs. Are there any available real world data evidence for safety events of JAK inhibitors in subgroups of patients with RA? So these are the types of adverse events we look for in these real world. Here's RCTs, here's real world evidence. We look at MACE, major adverse cardiovascular events, of course, herpes zoster, serious infectious events, GI purse, mortality, and malignancies. The big three are often thought to be MACE, serious infectious events, and malignancies. So these are phase 3 and 4 data published on the 3 JAK inhibitors that are now approved. Tofacitinib, baricitinib, and upadacitinib. And these drugs were studied as with methotrexate in complete responders, conventional DMARD in complete responders, and biologic DMARD in complete responders. I was fortunate to have participated in several of these trials across these 3 drugs. So the overview will include data from the United States Corona Registry, as well as claims databases from insurance. And these will include MarketScan, Medicare, and Optum. And this is, of course, within the US. So let's start out with serious infections and herpes zoster. This is from the randomized controlled trials, phase 1 through 3. The box of gray surrounded with blue is what we find from multiple published biologic DMARD trials. The red spot in the box is where the particular JAK that has the most data, tofacitinib, falls in relation to biologic DMARDs. And you can see that there is virtually no difference. TB, malignancy, non-melanoma skin cancer, MACE, GI purse, etc., and serious infection, except for herpes zoster, where clearly the incidence of zoster is increased with tofacitinib, as it is with all the other JAK inhibitors, compared to biologic DMARDs. This is the incidence in phase 2, 3, and 3B and 4 trials. Overall side effects broken down at patients less than 65 years old and patients greater than 65. And broken down for 5 milligrams BID and 10 milligrams BID. 10 milligrams BID has been shown, as is seen in this slide, to be associated with a greater incidence and prevalence of all toxicities, as is depicted here. And the incidence rate, as depicted on the vertical axis, is indeed greater on the 10 milligram BID dose. We are using the 5 milligram BID dose. although I recall vividly studying both doses. I personally like this dose and had no problems with it, but the data are the data. This is Corona, and Corona I actually founded a long time ago. And we now have an awful lot of data from like 42 of our 50 states. Lots of patients, lots of patient years. And I've been collecting data myself in Corona in my practice for a very long time. So baseline information comparing tofacitinib plus or minus conventional DMARDs with biologic DMARDs. So these are, again, baseline data. If you look at the CDAI scores, they're virtually the same. Concomitant conventional DMARDs. More conventional DMARDs are used with biologic DMARDs. And the prior utilization that is biologic DMARD naive patients, only 11.4%. And that reflects a lot of the earlier experience with tofacitinib and JAKs because we came to it late. It was our last resort. And certainly in the last several years, as I mentioned early on, we're using it much earlier, as compared with 31% with biologic DMARD. So in Corona, if we look at serious infectious events and herpes zoster, using propensity trimmed and propensity matched population. Propensity modeling makes sure that we're comparing apples with apples. So in the trimmed population, we eliminate subjects that are significantly different from the comparator group. So you really are for disease severity, disease duration, etc. Comparing the same types of patients. So for SIEs, for the trimmed and the matched population, there's no difference. For zoster, for both the trimmed and matched population, there is indeed a difference, which is not surprising, as we saw from the RCTs. Again, propensity trimmed and matched population, tofacitinib versus biologic DMARDs, virtually no different. If anything, tofa may be a bit better, but that is not a statistically defensible statement. Venous thromboembolism, which has been identified for the JAKs in general. Again, looking at phase 1, 2, 3, plus long-term extension, same model that we see compared to biologic DMARDs. There is, interestingly, for all of these outcomes, no difference. And you see in the red box, no difference in DVTs or PEs in the real world, which is kind of interesting. This is a dose comparison again from the RCTs, and adalimumab was a comparator in one of the RCTs with tofa. We're looking at 5 and 10 milligrams adalimumab, methotrexate, and the same for pulmonary emboli and DVTs. And in fact, there is no difference. A slight increase for DVTs with methotrexate. VTEs, venous thromboembolism, DVTs, and PEs. And again, really no difference of BDMARDs and TOFA for any of these three major outcomes. So there is indeed somewhat of a difference of the data that have been derived from randomized controlled trials versus real world evidence. And of course, in RCTs, a very small number of these events, 3 or 4 or 5, compared to perhaps 0 in over a 12-week period in the placebo group, would lead to the conclusion that these events are indeed more common. So there are challenges in trying to really get to the bottom of what adverse events in RCTs represent. And I'm not discounting them, but there are analytic challenges. The other database, the Medicare Market Scan, baseline characteristics, very large numbers of patients. The Medicare database in the United States, you have to be 65 to get Medicare. The average age is 71, and propensity score weighting was adjusted for 60 baseline criteria. And this is called a forest plot. And we have a mean and we have the confidence intervals. And here's the mean, here's the CIs. So if the confidence interval overlaps 1, it's not felt to be statistically significant. However, if the confidence interval is way out here with a tail that just overlaps 1, it may be clinically meaningful. I think it's appropriate to say from all these claims databases that there is no signal for a lower risk for TNF inhibitors versus tofacitinib for VTEs, confirming the data we saw from Corona. Again, this is real world evidence. Let's look at malignancy. Again, in the red box, lymphoma, malignancy, and MVSCs are well within the red box. There are individual studies which report malignancies, and malignancy is challenging in an RCT because malignancies develop slowly. So if you have a patient in RCT who develops a malignancy at week 12, did that really develop with the new intervention in the RCT, or was it present previously? Nevertheless, there seems to be no difference with the RCTs. In Corona, total cancer, propensity trimmed and matched, and non-melanoma skin cancer. And we know that this category is increased with TNF inhibitors, that there is indeed no difference. Real world US Corona data. So a summary of the safety data. The RCT data have highlighted the increased risk of zoster in patients receiving JAK inhibitors. More recently, venous thromboembolism has been identified as an important risk and has been included in the EMA prescribing information. The US Coronary Registry and claims databases show a similar incidence of adverse events of special interest, with no significant difference for either of those outcomes. So I'm going to go briefly over a few slides which really focus on the latest EULAR recommendations. And we're going to compare 2016 with 2019. So, and for the most part, there are very slight differences. In the treat to target regimen, when poor prognostic factors are present, a BDMARD or a TS-DMARD, targeted DMARD like a JAK inhibitor, is now recommended. They're both on the same shelf. That was not the case in 2016. It said it should be considered. Now they're on the same shelf. I want to focus on number 10. If a BDMARD or targeted DMARD has failed, treatment with another BDMARD or targeted DMARD should be considered. In the past, if you failed a targeted DMARD, and particularly if you failed TNF, it was stated that you can use another TNF. I think there's been a proliferation of really good papers showing that using a second TNF does not give the best results. You're really better off with an alternative MOA, mechanism of action, or our experiences with the targeted DMARD like tofacitinib. And this is very small to read for me, but here is the figure which represents this. So again, if you failed methotrexate, conventional DMARD, you add a biologic DMARD or a JAK inhibitor. If you have not responded, then we move over here and you either change the biologic DMARD or change the JAK inhibitor. So they're clearly on the same shelf conceptually for EULAR recommendations. So in summary, and I thank you for your attention. I have not personally participated in a lot of virtual conferences, and I imagine they may be somewhat more of a challenge. EULAR RA management recommendations have again been updated and recommended the use of a treat-to-target strategy for aiming for remission for at least low disease activity by appropriate instruments. That is, you have to measure Boolean remission, ACR, EULAR indices. Methotrexate plus short-term glucocorticoids are recommended as first therapy. We have a publication that's been submitted about the potential cardiac toxicity of short-term glucocorticoids in doses greater than 5 milligrams. Please avoid them for prolonged intervals. Newly confirmed as a strategy is similar in efficacy not only to anti-TNF, but also to abatacept and tocilizumab. And finally, once the above fails, any biologic DMARD or JAK inhibitor is recommended in order to aim for the therapeutic target. EULAR regards all these as having similar efficacy as I do. Thank you for your attention, and I will take any questions you might have.
Thank you very much, Professor Kramer, for very interesting data and overview. A lot of questions, but we're gonna, for the sake of time, we're gonna take 2 or 3 questions. So the first comment is the fact that the question that always comes: how confident are we about observation studies? They have deceived us more than a number of times, and we see the mess in the COVID-19 at this time. How can you defend such acquisition?
I think that's a legitimate question. Look, there is no study that's perfect. You may have biases with observational studies. There can be a channeling bias. They're not randomized, and there can be under-ascertainment in any observational study. Nevertheless, all of the registries around the world, in Europe and the US, have quality controls and have done their best to minimize the negatives and to frankly present the data in a context where it actually deserves to be treated. That's a good question.
You showed us clearly that JAK inhibitors are associated with increased risk for herpes zoster. So with that, would you recommend to vaccine any patient who's going to start on JAK inhibitor, regardless of their age?
Yes, I would. I think it's legitimate, but it begs some other questions. Do you hold methotrexate? Because all vaccines are less, we've learned in the last 2 years, are less efficacious than people on methotrexate. So I would hold methotrexate for a couple of weeks. I would use the full vaccine, not the live vaccine. And ideally, the vaccine is given prior to the initiation of any of these drugs. So the traditional interval for waiting is about 3 weeks, if you can.
Although clearly you showed us the the 2019 EULAR recommendation for the management of RA clearly stated that after the failure of conventional DMARDs, you can equally use, you know, the JAK inhibitors or any biological DMARD. Despite of that, why JAK inhibitors is considered as the first line treatment in USA and still second line in Europe after failure of biologic DMARDs?
Yeah, I do not know. And it makes no sense to me, honestly. Using these drugs, patients like a pill instead of a needle. And I'm a fan of biologic DMARDs, and patients have no problems with needles if they really get better. But these drugs really work. And as I said earlier, the more experience you gather with them, the more likely you are getting the feedback from your patients. The more likely you are to use them.
Okay, I think I'm going to stop here. I would like actually to thank both speakers, Dr. Omer and Professor Kramer, for the outstanding presentations. I hope that everyone enjoyed this session. I'm sure you have gained a lot of knowledge in short period of time. So the next session will start after 10 minutes from now. So please be back after 10 minutes. Thank you very much for attending, and I wish you a great evening. Thank you.